Hello class, this is Professor Streb, and today we'll be going over care of the patient with common metabolic problems, specifically diabetes. This is a big chapter. I know there's a lot to remember in diabetes. You will cover some of it here, but you will also cover more in 265 as you progress and get to your advanced med surg. For this exam, what we plan on doing is covering the things in your syllabus. You can see here on your screen is diabetes type 1 and type 2, sick day rules, things about hypoglycemia, a little bit on Somogyi phenomenon and Dawn phenomenon. So those are the things we're going to cover for this exam. But please note, it's important to go in your book and understand how the pancreas works, understand how the body uses insulin, how it uses glucose, and how it stores it and breaks it down. That is something we expect you to already know, so we're not covering it in class. If you don't know that, you definitely need to go back and read this in the book. I'm going to focus on the things that you as a nurse need to know specifically to care for these patients. All right, so type 1 diabetes, we typically refer to this as an autoimmune disorder. This is where the beta cells inside the pancreas itself are destroyed. They don't work. So they result in an absolute insulin deficiency. Your body does not have the insulin it needs to take blood sugar from the actual circulatory blood and move it into the cells itself. So that's what a type 1 diabetes is going to be. Most people who have type 1 diabetes, it's inherited genes. It's something they're born with, often seen in young people. It used to be called juvenile onset diabetes because it was in young people. That's no longer the case anymore because we see type 2 diabetics as well, starting at earlier ages. But when we think about a type 1 diabetic, we're talking about an insulin-dependent diabetic. Like I said, it's normally seen in the younger population. So make sure you understand as you're looking at patients who might be susceptible to diabetes, especially type 1 diabetes, we're looking for people who are, in their earlier 20s and, that nature. So younger people are who we're going to imagine are being at risk for type 1 diabetes. So in addition to the hyperglycemia, manifestations of diabetes mellitus include the 3 Ps. This is pretty universal: polyuria, polydipsia, polyphagia. You can go back and look at why, but it kind of all boils down to, if you think about the way the body works, if you don't have enough insulin to take all of the concentrated products out of the blood itself, your body is always going to shift fluid from your cells into the circulatory system when it is hyperosmotic. So there's a lot of particles inside your blood. Your body will go from an interstitial area, intercellular fluid will be shifted into the intravascular. As you start to overwhelm your circulatory system with fluid, it gets to your kidneys. Your kidneys can't keep up. That's why you pee a lot. Therefore, that's polyuria. You have polydipsia. You are thirsty once again because now all of the fluid is shifted from the cells into the blood volume and you pee it out. So you're thirsty. And polyphagia, you want to eat more because your brain is starving for glucose because all the glucose is now stuck in your blood, in your circulatory system, and you don't have any insulin to pull into the cells themselves. So that's why you have the 3 Ps. With these patients, we expect blurred vision, weakness, dizziness, fatigue, and all the other symptoms associated with diabetes mellitus. Type 2 diabetes is definitely different. Type 2 diabetics are the ones who, usually an adult onset, if you will. So type 2 diabetes is, you have limited beta cell response to hyperglycemic episodes. So when your blood sugar gets too high, you have desensitized beta cell response. So your glucose levels just won't get stabilized like they should. Now, typically, this can be mitigated by losing weight and exercising and eating better. So a lot of folks who have type 2 diabetes can virtually fix this problem by losing weight, by getting their BMI where it should, by eating the foods that they're supposed to eat to get a better glycemic control. So that's what our goal is going to be with these type of diabetics, especially the type 2 diabetic. When we think about these people, they're usually in their ages of 40, and they typically have adolescent obesity. We know that is more problematic in adolescent obesity, because now people are starting to get type 2 diabetes way before the age of 40. Older adults and minorities are at an increased risk for developing type 2 diabetes. We think about people who are socioeconomically depressed sometimes. In this country, that still is our Native American population, African American, Hispanic Americans. So there is a familia or a ethnicity type bias to diabetes type 2, but I think a lot of that also has to do with the socioeconomic issues faced by minorities in this country itself. So when you think about patients with diabetes mellitus, especially type 2 diabetes, they often have the traditional cardiovascular disease risk factors: obesity, high blood lipid levels, hypertension, sedentary lifestyle. We know that kidney disease, indicated by albuminuria, so if you have albumin in your urine, retinopathy, these are all associated with increased risk of coronary heart disease and mortality from coronary artery disease. So diabetes is right there with heart disease. They kind of go hand in hand. They're going to kill you. So it's important that if you have type 2 diabetes, you monitor it and you control it very well. So think about your patients in these high-risk groups, what kind of high risk they're at. So if you think about a type 2 diabetic, if they're not perfusing their kidneys correctly, like we just talked about here, what does that cause? If their kidneys aren't being perfused correctly, then they're going to start going into some kind of kidney failure as well, which we'll talk about next week. But diabetic neuropathy, that is why that occurs. And we often see these serum potassium levels super high in patients with type 2 diabetes because of this very reason that we just talked about. So things to keep in mind as you're really looking at your patients and trying to figure out how to differentiate between type 1s and type 2s and what you can do about it. Glucose monitoring is going to be one of the biggest things we as nurses do. If you go to page 1273, 1274, on page 1273, table 59.7, they talk about your A1C levels, which is definitely something you're going to have to kind of get in and know lab values. This is going to be your issue to really, I don't want to say memorize. You have to know lab values. You have to understand what normal looks like. Page 1274 talks about how to know you have good control when you start thinking about diabetes. What should you be looking at? What are the indications of a well-controlled glycemic index? So how do you know your patient's got good glycemic control? Page 1274 says an A1C level needs to be below 7%. The majority of pre-meal blood glucose, we're talking about a fasting glucose level, should be between 70 and 130. And then your peak after meal or your postprandial blood glucose should be less than 180 milligrams per deciliter. So these are things, if you're looking at your patient and you're trying to figure out, are they diabetic or not diabetic? Are they getting good glycemic control? You want to look at those three things to really determine if your patient's where they should be or are they kind of off. So like I said, make sure you go back and look at that so you can kind of get a better understanding for what that looks like. We know that hemoglobin A1C is really our gold standard for looking at long-term control of diabetes. It does a 90-day, a 3-month period, if you will. It lets us get a big picture for how your body is working. So when we think about measurements of A1C, they show the average blood glucose level during the previous 120 days. So we're talking 3 to 4 months there. So 90 to 100, it's about 120 days. So the lifespan of the blood cell itself is about 120 days. So we know that A1C testing helps us to assess that long-term glycemic control. And that's really what we're trying to figure out here. You can lie about the way you eat. You can lie about, blood sugar today. But the one thing you can't lie about is your A1C measures. And they will give us a good idea if you are indeed controlling your blood sugar the way you should be controlling your blood sugar. All right, self-care is going to be, it's big. So in your book, they talk about all kinds of self-care. You definitely want to go back and read in your book. You want to go back and look at a lot of the different headings that they have in your book that will give you a lot of patient and family teaching. That is going to be a big part of what you're going to do on this exam. You can't fix diabetes. That's not your job. But your job is a lot of patient teaching and self-care stuff. So we'll kind of go through that. You definitely want to focus on the education that promotes lifestyle changes, like we said, controlling your weight, exercising, the food choices have to be better. We know that this disease is very progressive, and it requires a commitment to modifying your lifestyle choices, but long term. Damage to your blood vessels is a leading cause of new cases of blindness and foot amputations in the United States, right? So we know that with these patients, we have to be very careful of their eyesight and their feet. So we're going to have another slide just on foot alone that we'll go back and look at that. All right, patient education has to focus on restoring and maintaining the blood glucose levels. So you want to kind of keep your blood glucose levels as close to normal as possible. You want to keep between that 70 and 110. Your book's got all kinds of different values. I think it says 76 or somewhere around there, but you kind of get the gist. 70 to just what it says in the book there. And around 70 to 110 is fine. Whatever the Galen value says, what you should go with. But this is what we're talking about for the most part. Dietary management is essential to improve the glucose levels. And we're going to talk about that just shortly as well. Physical activity is going to help lower your blood glucose by increasing the carbohydrate metabolism. So we're going to talk about patient exercise as well as being something that you have to kind of focus on in order to do what needs to be done. So in your book on page 1283, it says that regular exercise is an essential part of managing your diabetes, which we know this because it improves the carbohydrate metabolism and insulin sensitivity. But we know that increased physical activity and weight loss also reduce the risk factors for type 2 diabetes, especially if you have prediabetes. So we need you to have regular exercise. It not only does it help reduce the risk for cardiovascular disease, which goes hand in hand with diabetes, it decreases your blood lipid levels and increases your high density HDL, so your good cholesterol. So 1283 talks about the effects of exercise on diabetic patients. Page 1278, you go a little further back, table 59.8, it talks about timed activities of pharmaceutical insulins. This is going to be very important to you. You need to know when insulin is going to reach its peak, if you will. And why is that important with exercise? Because we know when somebody exercises, the body requires more glucose. So if you're not paying attention to the food you're eating and you're not paying attention to when your insulin is going to peak, it puts you at risk for hypoglycemic incidents. So if you think about your rapid acting insulins, you could think about any of them. Let's just go with a short acting insulin, like a regular, just regular human insulin. We know that the onset's usually about a half an hour, but the peak time is about 2 to 4 hours. So depending on when you take your medication, or if your patient takes their medication at a certain time, we have to worry about when it's going to peak and when it can cause the patient to be hypoglycemic. So if you're looking at a type 1 diabetic who might be given regular insulin and probably NPH as well, because we do a lot of combination medications because we want that to really kind of take effect, think about when they take the medication. If they take that medication at 8 in the morning, and we're talking about regular insulin, 2 to 4 hours later, it's going to peak 8, 9, 10, between 10 and 12 o'clock. That patient would have to worry about becoming hypoglycemic. If they're on NPH insulin, you need to understand the NPH insulin can come in anywhere from 4 to 12 hours. So if they take it at 8 o'clock in the morning, it might be closer to 4 or 5 in the afternoon where they have to worry about the potential for experiencing hypoglycemic effects. So as you're talking about exercising with your patients, make sure you go back to that page 1278, looking table 59.8, so you can understand better what the peak times are. Because let's just be honest, you're going to have to figure out when a patient is going to be experiencing hypoglycemia, especially on an exam, because that is part of the safety issue. Make sure that your patients understand that they need to adjust their carbohydrate intake when they have unplanned exercise. What is unplanned exercise? I don't know. Your car breaks down. You have to walk home. You have to walk an hour. You need to think about that. As a diabetic, you're going to have to adjust your carb intake to ensure that you don't get hypoglycemic. And then make sure that these people check their blood glucose frequently when exercising, because even just mild increases in exercise can increase the consumption of glucose within the blood. And they really need to be aware of how exercise is going to impact their ability to stay, how it's going to affect their blood glucose itself. Hydration is key before exercising. You want to consume carbohydrates as well, about 15 to 30 grams prior to exercising. If your glucose is less than 100, if it's more than that, then you're probably fine. But just ensure that you're talking to your patients about bringing some kind of snack with them. Having the ability to eat something if they start feeling some of the signs and symptoms of hypoglycemia, which we'll get to shortly. Foot care is big. Oh man, foot care is really big for these patients. Go to page 1288 again. Look at the patient and family education for self-management about foot care. There's a whole section on just foot care alone. But when you start thinking about what your patient needs to worry about with foot care, there's a lot. We talked about the micro blood vessels in your body and how they don't do very well when you have diabetes. That's exactly what happens when you think about your feet. Patients with diabetes have decreased blood flow to their feet, so they have all kinds of issues and things to worry about, not just in conjunction to the vascular system being less blood flow, but what that means. If you're not getting good blood flow to your distal extremities, you're going to have changes in neurological changes as well. So you're going to have less pain receptors. You're not going to feel warmth and cold like you would if you had good circulation. So it's imperative that we teach our patient to inspect their feet daily, especially in the areas between their toes. You need to wash your feet with lukewarm water and soap, right? You don't want to use scalding hot water. You don't want the patient to get into the bathtub feet first because they might not feel the water and how hot it is. That could also cause them to have burns. You would want to encourage them or discourage them from using like heating blankets or heating pads on their legs and feet, because just like a patient who has arterial peripheral artery disease, it's kind of the same thing with diabetes. Make sure as they're washing their feet, they dry their feet thoroughly. You never want to leave any kind of moisture between your toes, right? So if you are going to apply some kind of moisturizer to your feet, that's great after you bathe, but make sure you never apply that between the toes, because as you do, it can breed bacteria and cause some kind of breakdown. Like I said, go back in the book and look at this, changing your socks daily, especially the cotton socks. Don't wear the same shoes 2 days in a row. Just make sure you're aware of some of the teaching you need to be aware of and what you can talk to your patient about in terms of foot care. All right, insulin administration can be complicated, especially for a new diabetic. And you and I as nurses have a lot of knowledge on what you're supposed to do with this and how to make it work. Unfortunately, our patients aren't always as versed in administering insulin. So page 1277 talks about your rapid, short, intermittent, and long-acting forms of insulin and how they're injected. You can inject some of them separately. Sometimes they can be mixed in the same syringe, so that's going to bring up the need to understand that when you're mixing certain insulins, your rapid, short-acting insulins are your emergency insulins. They are supposed to work instantly to lower your blood sugar. You would never want to dilute that with a long-acting form. So as you're getting ready to mix insulins, go back in your book and look at this. You would always want to inject air into the long-acting first and then inject air in the short or rapid-acting. Then draw up the rapid-acting medication before you drop the long-term or intermittent acting medication, so you never dilute your rapid-acting emergency medication. It also talks about insulin absorption is affected by many factors, including the injection site, the time, the type, the dose, all that kind of stuff, and physical activity. We know that injection sites do affect the speed of insulin absorption. Figure 59.4 in your book talks about some of the insulin injection areas that are commonly used. We know that absorption is fastest in the abdomen. So we expect this, right? That if you inject your insulin into your abdomen, don't forget it needs to be at least 2-inch radius away from the navel area. That's the preferred site because of the rate of absorption. However, if you're going to do physical activity, do a bunch of crunches that day, you probably wouldn't want to inject it in your stomach because that could cause a more rapid absorption of the fluid. So the things to think about: the injection depth. You know, we're doing subcutaneous injections here. It's not intramuscular. If the patient if they have limited mobility, make sure they understand the best place to do it. The larger muscle groups are typically the best place. You know, the larger areas, the thighs, the stomachs. These are better areas to inject your insulin for better absorption rates. Make sure you change the sites, but if they do change the site, they need to understand the absorption rates will change. So these are the things that, like I said, go back and look on that book in the book on page 1277 and then figure 59.4. It'll give you some really good insight on what to teach your patient about insulin administration. Insulin pumps, we don't deal with these a lot inpatient, outpatient for sure. There are plenty of alternative methods of insulin administration that are available besides the traditional sub-Q injection that we give in the hospital. Insulin infusion pumps, needleless injection systems, dry powder inhalers, you've seen them all. What we're thinking about with these is the basal dose of insulin is delivered continuously. So it gives you a better regulation. So the pump regulates the patient's blood sugar and improves the hemoglobin levels. It's just a better glycemic control when you use an insulin pump. All right, a couple more slides. Sick day rules. This is something that you're going to have to become familiar with as a nurse. Like it or not, it just becomes something that has to be second nature to you. Page 1294 has a patient and family education box specifically on sick day rules. I keep mentioning these boxes in your books because let's just be honest, your job as a nurse focuses heavily on patient and family education. If you're not looking at these in the book, you're not doing yourself justice on nursing exams. The patho and all that is great. We already expect you to know that, so we're not going to test you over that. You were tested over that in your other classes. However, we expect you know it. That's why we're going to ask you questions, and if you don't know it, you're probably not going to do well. So I'm only focusing on the things that you need to know based on your previous knowledge. So go back and look at these patient and family education boxes in each one of the chapters. Sick day rules talks about, when you're ill, we know that illnesses result in dehydration. And when you're dehydrated, especially as a diabetic, we can get into something called DKA or HHS, which we're not going to get into this term. That'll be 265. But just be aware that when you are sick, your body still needs insulin. As a matter of fact, it needs more insulin than it typically does because your body, when you're sick, requires a lot of glucose. So insulin therapy should never be omitted during illness, even if you're not eating. Make sure you let your doctor know if they're sick. Make sure they're monitoring their blood glucose at least every 4 hours, that they test their urine for ketones if their glucose gets above 240. That might mean they're breaking down fat stores, and that could release ketones in their urine. It can lead to acidosis. Like I said, that's next term. But make sure they continue to take their insulin regardless if they eat or not, right? To prevent dehydration. They're drinking 8 to 12 ounces of water every single hour, about a cup an hour, while they're awake. Sugar-free liquid, of course, unless they have hypoglycemia, then they would do some kind of fruit drink or drink that contains sugar. But like I said, make sure you're talking to your patient about continuing to eat meals at a regular interval. Think about anything. Any trauma to your body is going to cause your glucose levels, the need to go up. So if your patient is super sick and let's just say they're a type 2 diabetic and they're really, really ill or they're going to have surgery, even a type 2 diabetic might need to go on insulin injections during these times of sickness. So sick day rules might include a type 2 diabetic taking insulin injections for that short duration while they get through their sickness themselves. And let's just continue with this. If I am sick and I have diabetes, we are also being aware that your blood sugar is going to continue to climb because your body, even if you're not eating, your body's going to break down fat stores, and it's going to release the glucose into your blood. But without insulin, it's not going to be able to pull it out of the intravascular circulation and into the cellular where it belongs. So your patients are going to have signs and symptoms of hyperglycemia as well. All right, hypoglycemia, this is big for a lot of people with diabetes. Page 1290 also talks about patient and family education, management of hypoglycemia at home. We know that hypoglycemia is just low glucose levels, and they're very specific symptoms. It typically resolves once your blood glucose level gets back above 70, but there's a sequence of events that begins with the release of counter-regulatory hormones once your blood glucose level falls below 70 milligrams per deciliter. So your autonomic nervous system is going to kick in. You're going to have production of neurogenic and so just different kind of symptoms. So peripheral autonomic symptoms include sweating, that cool, clammy skin, irritability, tremors, anxiety, tachycardia, hunger. I like to think about this as being hangry, right? When you start to get a little hypoglycemic, the first signs and symptoms are going to be that cool, clammy, sweaty, irritability. Your body's saying, hey, look, I need some glucose. That occurs way before the symptoms of confusion, seizures, coma, and basically brain death at some point. When your brain is deprived of glucose, it will eventually go there. Like I said, at this point, though, think about the early signs and symptoms of what you're going to be monitoring for. So expect your patients to tell you they're cool and clammy. Expect them to say that they're a little, anxious or irritable. Kind of the same thing. If your patient is hypoglycemic, that page I was telling you in the book, go back and look there again at 1290. It talks about how to have your patients take whatever. So if they're conscious and they can talk to you, the plan is usually to treat hypoglycemia with like 15 grams of some kind of carbohydrate, right? So you could take glucose tablets, drink a half a cup of fruit juice or regular non-diet soft drink, something with sugar in it. Typically not orange juice, because orange juice can have an issue with your potassium levels, but that's for a later date. 8 ounces of skim milk, some tar candies, whatever. It talks a lot in there. Just make sure you're aware of some of the things that you would offer your patient who is hypoglycemic and able to swallow. If they're unable to swallow, make sure they don't put anything in their mouth. If they're at home with their family members and they become unresponsive and they do a blood glucose and it's like 30, what are you going to do? You might need to teach the family how to administer some kind of glucagon IM. Just because they're not in a hospital doesn't mean they don't get shots. So part of your teaching would be the administration of an intramuscular glucagon or something like that as needed by family members. So, like I said, what you give your patient to bring their blood sugar up depends on both the level they're already at as far as their blood glucose and their consciousness and their ability to swallow. Yeah, so there you go. The last two things we're going to talk about are Somogyi phenomenon and the dawn phenomenon. These confuse a lot of people. These two conditions are, they're what we call conditions of fasting hyperglycemia. What does that mean? It means that you didn't eat anything, but then you have hyperglycemia. How does that work? You can go back and look in your book. I'll give you some page numbers there. I think it's figure 59.5. But Somogyi phenomenon, this is what we call morning hyperglycemia, right? So rebound hyperglycemia. What does that mean? So as you're asleep at nighttime, your glucose levels drop drastically low, so you're hypoglycemic. It's managed by making sure that somebody eats before bedtime. So when I think Somogyi, I think Somogyi sandwich. Yes, I said sandwich because I like saying it that way. But Somogyi and sandwich. If you eat a snack before bedtime, you will prevent nighttime hypoglycemia, and in turn, you will prevent that Somogyi phenomenon where you have hyperglycemia in the morning. So it's not uncommon to see, glucose levels where if you were to take glucose levels at nighttime before bed, Q hour of sleep, they're 90, they're 90 on their glucose, which is fine. But if you were to do a night, not midnight, but like maybe 1 o'clock in the morning, 2 o'clock in the morning, so sometime mid-sleep, you would notice that their glucose levels are low, 50s, 60s, somewhere in that area. And then when they wake up in the morning, they're going to have a glucose level of like, 225 or something. So when we think about Somogyi is rebound hyperglycemia, meaning somewhere in the middle of the night, their blood sugar gets really low, their body compensates, and they wake up with high glucose. That can be prevented by giving them a sandwich or something to eat prior to bed. When we look at dawn phenomenon, this results from a nighttime release of adrenal hormone. So this is a hormonal issue. This causes the blood glucose elevation at about 5 or 6 in the morning, so early morning, not like 2 in the morning or in the middle of the night, but like very, very early in the morning, 5, 6 in the morning. But this is managed by providing more insulin for overnight periods. So if you give an evening dose of an intermittent, like an intermittent acting insulin around 10 p.m., instead of giving it with the meal, it will last longer, so they won't wake up with hyperglycemia, as the insulin will release a little slower and it'll release throughout the night. So Somogyi sandwich, feed your patient. Dawn phenomenon, as they wake up, they need another dose, right? Dawn they need a dose of insulin before bed, and that'll usually take care of it. All right, hope that helps, and we'll talk soon.